In the initial broadcast of this session, Medicaid as a Linchpin, Truth and Consequences, we highlighted what might happen to children and families as a result of some of the proposed shifts in Medicaid and healthcare policy. As we prepare to rebroadcast that engaging, informative session from May of this year, we wanted to start the conversation with some brief updates and an understanding of the implications of the legislation that was actually signed into law on July 4th of this year, H.R. 1. And for that, I'm delighted to welcome Ann Dwyer back to the conversation. As a reminder, Ann is an associate research professor in the Georgetown University Center for Children and Families. So thank you so much, Ann, for coming back to share some updates with us today.
It's great to be here, Sarah. Thanks for having me back.
So in the initial conversation, when you joined us in May, you shared data on the vast populations of children and families served by Medicaid. And attendees will get a chance to hear all of that information in just a second. But for right now, I just wanted to invite you to share some of the critical headlines about H.R. 1 in terms of its impact on access to care for children and families.
Of course, yeah. So a number of updates since I last was able to speak with folks in May. So notably on July 4th in 2025, so just this past July, President Trump signed the Congressional Republican Budget Reconciliation Bill into law, so also known as H.R. 1. So the Budget Reconciliation Law includes numerous provisions related to Medicaid and the Children's Health Insurance Program, also known as CHIP, which, to be frank, institute deep, damaging cuts to the programs. So according to the final Congressional Budget Office cost estimates, which came out after passage of the bill on July 21st, 2025, so just less than about 2 or 3 weeks ago now, the law's Medicaid and CHIP provisions would cut gross federal Medicaid and CHIP spending by over $900 billion over the next 10 years. And again, that's just the federal side of things. So it doesn't even take into the state impact, given that Medicaid is a state-federal partnership with a federal and state match. So, it's, as we talked about a little bit during our discussion in May, it's important to note that only a handful of these Medicaid and CHIP provisions can be viewed as addressing fraud, waste, and abuse, but they only account for, according to our estimates, about 2.5% of the gross Medicaid and CHIP cuts. Instead, states will face significant cost shifts under some of the major Medicaid and CHIP cuts. At the same time, states will face other large cost shifts for SNAP benefits under the law and under the Affordable Care Act. So while CBO in its estimate from July 21st does not break down coverage impacts by population, the final CBO estimate finds that the number of uninsured individuals overall would increase by a net 10 million in 2034. And although Medicaid expansion adults are the top targets under the reconciliation law, this includes low-income parents, many low-income populations are at risk or loss of Medicaid coverage under the bill. So this includes children and families, women, especially those of reproductive age living in small towns and rural areas, people with disabilities, low-income seniors on Medicare, veterans, and legal immigrants, including refugees, victims of domestic abuse, and people seeking asylum. So in addition, a wide range of providers, including those who serve children, will lose Medicaid revenues under the law. This includes safety net hospitals, rural hospitals, children's hospitals, and community health providers. And I just wanted to talk a little bit as an update today in more detail about that rural component. So when it comes to rural communities and providers in particular, it is expected that Medicaid and CHIP cuts in the budget reconciliation law will have a severe adverse impact on residents of rural communities and the hospitals and other providers that serve them. So residents of rural communities, including children, non-elderly adults, and women of childbearing age, disproportionately rely on Medicaid and CHIP for their health coverage. So we have a report on this on the website. I think I talked about this a little bit during my remarks in May. In addition, the Urban Institute estimates that an earlier Senate version of the budget reconciliation legislation, including the failure to extend the expiring enhanced marketplace subsidies, so those are the enhanced ACA tax credits for health coverage, would have reduced revenues to rural hospitals by $87 billion over the 10 years window that they looked at, and increased uncompensated care costs by $23 billion. Similarly, KFF estimates that an earlier version of the reconciliation bill will would have cut federal Medicaid spending in rural areas by $155 billion over 10 years. And again, this isn't accounting for reductions in state spending. So I provide this context because I do want to note that in the final law, it does create a rural health transformation fund. So in total, this rural health transformation fund, which is a new bucket of federal dollars, will have $50 million in federal funding. $10 billion for each of fiscal years 2026 through 2030 is how it's set up. And it will be allocated to states with approved applications and can be spent on a variety of purposes, including but not limited to payments to healthcare providers. But it's important to note that this fund is unfortunately unlikely to really significantly mitigate the harm to rural providers under the budget reconciliation bill, or a law, I should say now. So the size of the fund is much smaller than the expected financial hit to rural hospitals and other providers. This fund is also temporary. It is available for only 5 years, while the other Medicaid and CHIP provisions deeply cutting federal Medicaid and CHIP spending are permanent. And with those cuts getting larger over time and extending beyond that 10-year window. So CBO is giving us this, what happens over the next 10 years, but those cuts go into perpetuity. Moreover, the fund is poorly targeted, giving discretion over a large portion of the funds to the Secretary of HHS. So these are the funds in the Rural Health Transformation Fund. And again, does not require a specific, include a specific requirement that states actually spend the money or give the money to rural providers. So ultimately, rural residents are likely to face disproportionate coverage losses under the budget reconciliation law. Again, they're going to have severe reductions in federal Medicaid spending, and rural hospitals will experience substantial revenue losses and increases in uncompensated care. So this rural fund will at best mitigate some of this, but it will not make up for all the losses. I will say on a positive note, there were no cuts directly to school Medicaid services included in the law. I know we talked quite a bit about kind of the role Medicaid plays in supporting children and students. However, I will note that, again, the law puts immense pressure on state fiscal budgets. So as a result, states will likely be faced with decisions to raise taxes, reallocate funds from other part of their state budgets, where we know K through 12 funding is often the biggest state budget item, and or cut Medicaid benefits, coverage, or provider payments, which could ultimately impact school-based services and coverage. In addition, it's important to keep in mind that children are more likely to be covered if their parents are covered. So there's a real concern that more children could experience gaps in coverage as a result of the law, in part due to their coverage or their parents experiencing coverage gaps. And finally, on that note, as I mentioned in my previous remarks in May, evidence has linked a boost in children's reading scores with when their parents become newly eligible for Medicaid coverage. Yet, as I mentioned earlier in my remarks, there are a number of provisions in the law that target Medicaid expansion adults in particular. Again, this includes low-income parents, including new mandatory work requirements, which are expected to lead millions of adults losing their health coverage, and again, including low-income parents losing their coverage. This is despite multiple analyses, including from the Nonpartisan Congressional Budget Office, finding that such work requirements have little to no effect on employment or hours worked. So the savings from this bill is really coming from individuals losing their health coverage. So all to say, this law will have, damaging impacts on healthcare coverage and access for children and their families. And we have much work ahead of us in the coming weeks, months, and years ahead as these changes go into effect.
Wow, that was a great overview of some really concerning headlines and updates. And you did share a couple of bright spots where things didn't end up being as bad as it could have been. Are there any other kind of examples of good news that come out of the actual law that was passed?
Yeah, I appreciate you bringing it up, because there are many concerning provision changes in the law, but there are a few positive highlights. In part, highlighting a few things that were in initial versions of the bill that did get kicked out or dropped out. So because of the Senate budget process, they have special rules in the Senate, sometimes referred to as the Byrd rule, that certain provisions have to meet they have to be budgetary, not policy in nature. They have to meet certain tests. We ultimately saw a number of harmful provisions get kicked out of the final bill. So this includes provisions that would have targeted state decisions to cover undocumented children with state-only dollars. So you may remember there was a provision in the bill that said expansion states would lose part of their expansion matching rate if the state made a state decision to use state-only money to cover undocumented individuals, including children. So that ultimately did get kicked out of the final bill or dropped from the final bill. And we also saw protections for children in the Children's Health Insurance Program, or CHIP, that were going to be undone. That provision that was going to undo them got kicked out of the final bill. So just to unpack that second piece a little bit more. So earlier versions of the bill included language placing a moratorium on all of the provisions of the Medicaid and CHIP eligibility and enrollment rule. This was a rule that was finalized under the Biden administration in April 2024. It was about making coverage more streamlined, making it easier for individuals to enroll in coverage, in particular seniors, people with disabilities, and making a number of improvements to the Children's Health Insurance Program. There, in the earlier versions, it was going to put a moratorium on all of those improvements. But ultimately, due to dynamics related to the Senate Byrd rule, the final language of the budget reconciliation law that was passed, so HR 1, blocking the rule through September 2034, did not include provisions that of the rule that were already in effect. So basically, any provisions that were already in effect when Congress was considering this law could move forward, and they could only block things that hadn't gone into effect yet. This is a positive for CHIP because there were a number of improvements to CHIP that went into effect June 3rd, so just about a month earlier. So they just kind of get in under just got in under the end there. So this includes new rules prohibiting waiting periods, premium lockouts, dollar limits on CHIP benefits. So some policies that were in CHIP previously, including waiting periods, right? Like forced periods of uninsurance for children that states had the option to, and a number of states did implement. Those new rules preventing either new states from picking those up or states that had those provisions from they had to eliminate them and come into compliance with the elimination of those provisions, that was able to move forward. So that is, net positive there. But again, those originally were included into the 2024. So it was really just a question of whether or not they got put under the final law. There were a number of other positive changes under that 2024 rule that had not yet gone into effect. And unfortunately, those do have a moratorium on them for a 10-year period until 2034. In addition, we're not clear if it was intentional or not. I really don't know. The law also creates a new option to extend retroactive eligibility to children under CHIP. So a state can give children in CHIP 60 days retroactive eligibility. This is particularly important. Let's say a family has a medical emergency or crisis. They go in, they realize their child could get coverage for CHIP, but it takes a few weeks to get, or a few days even, to get all the paperwork together. This provides 60 days retroactive eligibility if that child would have otherwise been eligible. So it just really helps in those emergency situations in particular. However, I will note overall the bill reduced retroactive eligibility in Medicaid. So it used to be 90 days, they reduced it to 60 days, and then the 30 days for expansion adults. So it's has limiting effects, but CHIP kind of got wrapped into that 60 days. And finally, there are some, notable silver linings on some of this stuff, in particular things because of the budget process and the Byrd rule that ultimately got left out of the final language. But I'd be remiss if I didn't note that despite the gains for children enrolled in CHIP under some of these changes that we saw at the very end, the Trump administration last week worsened the outlook for babies and toddlers to have uninterrupted access to care by announcing their intention to eliminate Section 1115 waivers in Medicaid and CHIP focused on continuous coverage for young children. So these for states that wanted to allow kids until they go to kindergarten to keep if they were on Medicaid or CHIP, to keep that coverage, to not be worried about churn, about coming off in coverage, making sure they're getting all their well child visits. A number of states proactively requested waivers for this. Some got approved, others were kind of waiting, getting their applications together or waiting for approval. And the administration came out and said that they're not going to approve any more of these waivers, and they'll be winding down the ones that are out there. So that is unfortunately a big loss for a really beneficial policy that we are starting to see states pick up.
Yeah, that's unfortunate. So with the biggest cuts and a lot of these new requirements not really scheduled to come into effect until the end of 2026, Are there any things that we can do, child advocates, now to protect children and families from some of the worst impacts coming out of the passage of HR 1?
Yeah. So I have a few things I think advocates and others can think about as these changes roll out. So, like, number one, educate yourself and others on the changes that are coming or that are here, including the timeline. So, as you know, some of these changes are coming later, 2026. Some of these changes are in effect now. So, for example, retroactive coverage changes in effect now, changes to certain immigrant populations, legal immigrants who are now no longer eligible to get Medicaid in certain cases. Um, there's some Medicaid financing changes, some of which are come into effect right now, some are later, some get phased in over time. So again, would really encourage you all, to the extent you want to really engage, educate yourself. We have a great explainer on our website. It's relatively plain English, as much as Medicaid policy and CHIP policy can be plain English, but takes the legislative language, breaks it down into kind of, again, like real world talk in our explainer. And then at the end, we also have a timeline of the effective dates for everything. So people can keep track of, okay, what's going on now, what's coming, how can I think about preparing? So again, educate yourself, educate others. Two, track and document what you're seeing in the field. Are kids you're working with losing their health coverage? Are their parents losing their health coverage? Are their community providers closing their doors? And if so, what does that mean for them and their families? Data and storytelling is going to be a key part of trying to get a sense of how this is all playing out on the ground. And I think those on the ground and state advocates and education advocates can really play an important role in kind of collecting that information. So educate, track, document. Third, accountability. I think that really goes with the track and document, making sure that those who have made some of these decisions really understand what the impact looks like on the ground. So as we gather this impact, again, holding individuals accountable, making sure that they understand how this is playing out, whether it's playing out the way they intended, not intended, but again, making sure that they're held accountable for these types of decisions. And finally, mitigate. States are going to be faced with some very difficult decisions in the coming weeks, months, years. Many of the Medicaid cuts in the bill will really push down to the governors and the states to be the ones to make the hard decisions about how these cuts play out. So really working within states to try and mitigate as much of the harm as possible. For example, how work requirements are implemented or how states decide to fill budget holes. These will really be critical decisions moving forward, and it's a place where state advocates their voice can really have, and child advocates can have a meaningful impact. And there are, again, opportunities here, in particular, as states, they are required to do these work requirements, but how they're implemented, how well they're done, or how poorly they're done really mean a huge difference. For example, parents with children under a certain age, 13, are supposed to be exempted. Whether that's actually true, whether that's happening, those are going to be really important decisions in terms of a coverage impact. And then finally, I note this is a lot to track. And so just reminding folks, we at CCF do regular updates. We have a blog, we put out reports, but just we have a newsletter that goes on Fridays where we kind of just put the latest and greatest, what's going on, blogs on different topics that folks are interested in digging down into. So we just encourage you, to the extent you're trying to kind of keep tabs on this, our weekly newsletter, I think, is a good place to just have something in your inbox if you're interested to go to kind of track what's going on.
That is really helpful. I know for a fact that your site is a wealth of resource and information. I've been digging into it recently, so we'll definitely share that link in the chat as well as in the follow-up email to registrants. But really, just thank you so much, and for especially kind of ending on the note of, like, there are things that we can still do. I mean, it is a pretty dire situation, I feel like, right now for children and families and those of us who care about ensuring they have access to healthcare. But educating ourselves, capturing the stories, sharing the stories, kind of changing the narrative about the importance and the impact that this is going to have, holding folks accountable, and then, like, with so much power going to the states, making sure that implementation is done in a way that is
least amount of harm, right?
Exactly.
Yeah.
Yes. Instead of, when it's no longer do no harm, it's like, let's lessen the harm, I guess.
Yeah.
But anyway, thank you so much again for joining us, and for all of the work that you do at the Center for Children and Families.
It's great to be here, and thank you to you and to, everyone who's listening into this for everything that you do every day to support children and families.
Well, I have the opportunity to introduce Dr. Robert K. Ross, who will act as our moderator for today's conversation. Bob served as President and Chief Executive Officer of the California Endowment, a private statewide foundation to address the health needs of Californians. Dr. Ross has been involved in community and professional activities at both the local and national levels, including being elected to the AIR Board of Directors in 2024, serving as founding board member of Covered California, chair of the Los Angeles County Task Force on Alternatives to Incarceration, and on the President's Advisory Commission on Educational Excellence for African Americans and the Diversity in Philanthropy Coalition. Bob, I welcome you to join us and thank you again for sharing your time and expertise today, and I'll turn it over to you. Thank you.
Good morning to the warriors and advocates of the fantastic and terrific campaign for grade level reading across the country. An important and timely webinar today with an issue that is important to each and every one of us on this call and in your work as advocates for children and families. I want to acknowledge before I get into my framing comments. Thank you, Sarah. Thank you, Michelle. Thank you, Sarah, for organizing and providing the logistical leadership and support for these and other webinars. And a shout out to my friend and colleague, long 40-year plus colleague, Ralph Smith. He and I have been in the trenches from various perspectives, fighting for cobbling together a system of support and thriving and nourishment for children and families at the intersection of health and education and social services. So thank you, Ralph, for your enduring leadership, my friend. A timely moment that we find ourselves in for various reasons, but let me start big picture. 200 years ago, a French sociologist named Alexis de Tocqueville arrived at the United States to study how this new democracy for all was going. It was in the 1820s. At that time, Europe was led by monarchs and kings and queens and czars, and the United States was this fledgling adolescent trying to learn how democracy for all works. And in his book, Democracy in America, which is not an easy read, but he makes some salient observations about where America was at the time. He kind of gives America a grade of incomplete in trying to assert a for-all representative democracy. We still had slavery, which he noted at the time that would have to be fixed. But for all of the promise and struggles of an 1820s America, he did offer this quote, which reminds me of our conversation, a good frame for our conversation today. And he said, "The greatness of America lies not in being more enlightened than any other nation, but rather in her ability to repair her faults." Repair her faults. And he presently reminded us at that time that a thriving for-all democracy is a long game. And here we are 200 years later, still trying to get many of these elements right. FDR tried health for all in the 1920s and 30s, was not successful. Truman gave it a try in the 1950s, was not successful. But in the 1960s, Lyndon Baines Johnson provided leadership, first in 1964 on the Civil Rights and Voting Rights Act, followed by the advent of Medicare and Medicaid in 1965. And so now Medicaid is 60 years old. It continues to address a key fault, going back to Tocqueville, in our nation, and that is we don't have a national policy that assures health care and health coverage for all of its citizens and residents. And so today, this is a program that serves more than 75 million Americans, more than 35 million children, including 7 million children plus in the CHIP program. And we now find ourselves at a 60-year moment in the Medicaid program, re-examining the impact, the present, and the future of this incredibly important program for children and families. It is under heightened scrutiny and public debate. It's critical that we understand what is truly at stake, and this is what the purpose of today's webinar is. And Medicaid's impact goes beyond the doctor's office and goes beyond the matter of just coverage. It touches school-based health services, supports children with disabilities, it sustains healthcare providers in under-resourced communities, and it's the backbone of our public systems, both on the health side and on the education side and the social services side. And we pull on that thread, the entire fabric begins to fray. So today's conversation will explore how Medicaid policy connects directly to educational opportunity, to family stability, to long-term community health. And we hope that this session equips you with some insights and a renewed sense of urgency, as this program is now budgetarily under debate at the federal level, to ensure children remain at the center and not as collateral damage in these critical policy decisions. We have an incredibly terrific panel today. I couldn't think of a better group of well-placed individuals and professionals to speak to the issues that the challenges that Medicaid faces today. We have Paula Andahar, who is a senior policy specialist at the National Association for the Education of Young Children, also known as NACCE. We have Ann Dwyer, JD MP, who's an associate professor, research professor at the Center for Children and Families and at the McCourt School of Public Policy at Georgetown University. We've got from Utah, Mo Hickey, executive director of the Voices for Utah Children. And we've got the Honorable Jessica Schubel, former special assistant to President Biden for healthcare and founder of Day One Strategies. Each of these individuals spending an enormous amount of advocacy, energy, passion, and time on the matter of the future of children and their well-being. And so I just want to thank each and every one of them for joining us today. I will start off by providing Ann Dwyer, Ann Dwyer, with an opportunity to frame where Medicaid is today through data and insights and its impact on child health and development. So let's hand this over to Ann. And Ann, take it away. What does our audience and colleagues need to know about children and Medicaid and CHIP and the broader impact of Medicaid beyond direct healthcare services?
Great. Yes. Thank you, Dr. Ross, for that powerful introduction and for having me here today. So I'm going to talk a little bit high level briefly about what's kind of going on at the federal level, and then take it back a step to talk about why Medicaid is so important and the role it plays in coverage for children and families across the country. So as Dr. Ross highlighted, there is a lot going on at the federal level. So as we speak, they should have started actually about an hour ago. The House Energy and Commerce Committee on Capitol Hill is having a markup of their hearing on their draft reconciliation bill. This language was just released a day or two ago, so lots of folks unpacking it. But I did want to highlight that according to preliminary estimates from the Nonpartisan Congressional Budget Office, the E&C Committee's draft bill would cut at least $715 billion in federal spending over the next 10 years, with a vast majority of that coming from Medicaid. In addition, the, again, nonpartisan independent Congressional Budget Office has noted in their analysis of this draft text that 8.6 million people will become uninsured as a consequence of the bill's Medicaid and ACA marketplace provisions, with the Medicaid policies in the bill driving nearly all of those coverage losses. This, combined with the expiration of the Enhanced Affordable Care Act marketplace subsidies and other ACA-related provisions, and another committee's version of the bill that will kind of get combined together at the end, coverage losses, if this were to move forward, would be well over 14 million people, according to estimates. But again, before we kind of get into more discussion, which I know we will today, about some of the federal debate and the impact on Medicaid, I wanted to provide a bit more background on the role that Medicaid plays in the US healthcare system, and particularly for children. So as we can see on this slide, Medicaid covers about half of children across the country. This includes all children in foster care. It also covers about half of children with special healthcare needs. A lot of folks don't realize that you can have private insurance and Medicaid, and there are children with special healthcare needs who have private coverage, but that coverage is perhaps unaffordable, high deductibles, or often, especially for children that need, home and community-based services, long-term services and supports, not comprehensive. And they also rely on Medicaid to help ensure that they get the things they need. Medicaid, as I mentioned, is also it's the primary payer of behavior or long-term services and supports in the United States. So Medicare, I think a lot of folks think of Medicare as the aging program, which it is, but Medicare does not cover a lot of long-term services and supports, including much of longer nursing home stays or home and community-based services. Medicaid is the primary payer of those services in the U.S. And as I was about to mention, Medicaid is also the single largest payer of substance use disorder treatment and mental health services. And it really plays a key role for both rural and urban communities. In fact, according to a recent CCF report on kind of rural impact, non-elderly adults and children in small towns and rural areas are more likely than those living in metro areas to rely on Medicaid and Medicaid's smaller but important sister program, CHIP, for their health coverage. And finally, as we've seen with COVID-19 and Hurricane Katrina, as well as other natural disasters, Medicaid plays a really important role when it comes to addressing pandemics and natural disasters. Next slide. So the next few slides, I'll move forward a bit more quickly, but I wanted to call out a few specific areas in more detail that I mentioned. So as Dr. Ross mentioned, Medicaid plays a really important role when it comes to services across child-serving systems. So in addition to healthcare, Medicaid plays a role in supporting the education system by covering Medicaid-based school services, as I mentioned, disability services, but also a very large role in the child welfare system, as well as many others. Next slide. And when it comes to kids, Medicaid and CHIP provide health coverage to about half of all kids, as we can see here, is by far the largest source of health coverage for low-income children under 6. So this is looking at children under 200% of the federal poverty level, under the age of 6. Medicaid and CHIP coverage is about 75% of those kids. So again, a really important program for millions of children across the country. Next slide. And also, as I mentioned, Medicaid is the primary payer of covering about 40% of paying for about 40% of births across the nation. This can vary. So we have this information on the CCF website, but you can look at your state here. Many states, Medicaid pays for well over 50% of births in the state. So those are kind of highlighted in the darker blue on this map. So again, a really important program when we're talking about coverage of pregnancy-related care in the United States. Next slide. And of course, in addition to coverage for pregnant individuals and for children, Medicaid also plays a really important role in covering other individuals as well, both working-aged adults and older adults. So overall, Medicaid provides health coverage to about 72 million low-income children, adults, and seniors. And this includes many low-income parents, many of whom are covered through Medicaid expansion pathway. So sometimes Medicaid expansion pathways talk about kind of like single childless adults, but the reality is that many low-income parents in many states are covered through the expansion pathway. And we can kind of see that gap here on this chart between the light blue line, where in states without Medicaid expansion, they're only covering low-income parents up to about 34% of the poverty level, which is a very low amount. Whereas parents in expansion states have that coverage up to 138% of the poverty level. Next slide. And when it comes to Medicaid and students, Medicaid is critically important. So it provides students with access to the care they really need to show up for school ready to learn. So for example, children covered by Medicaid are more likely to receive the preventative health care that keeps them in school, annual checkups that allow them to participate in sports, and treatment when they are sick or injured. And all these benefits really add up to stronger, healthier students, boosting both school achievement and economic prosperity as adults. So in fact, research shows us that students eligible for Medicaid are more likely to graduate from high school and complete college than students without access to healthcare. And if you're interested, as you can see on this kind of graphic on the right here with the lots of dots, we have Medicaid and CHIP coverage by school district, by state on our website. So if you are interested in your state by school district Medicaid and CHIP coverage, feel free to check out our website and track that down, and you can get a sense of how many children in that school district are covered by Medicaid and CHIP. Next slide. And when it comes to this longer term impact, we also see that one study found that increases in Medicaid eligibility at birth lead to improvements in reading test scores in the 4th and 8th grades. Another analysis found a boost in children's reading scores when their parents became newly eligible for Medicaid coverage. So we know that connection. Children whose parents are covered are more likely to be covered themselves. And this long-term investment goes well beyond the immediate school years. So for example, 2023 Congressional Budget Office analysis, again, this is this independent nonpartisan office, found that just one extra year of Medicaid coverage during childhood leads to higher earnings and better productivity as an adult, boosting the nation's economy. Next slide. So I will wrap up there because I know we have a lot to cover today. And I'll just note we have, as I mentioned, a ton of resources on the CCF website. So we have a number of mini briefs, including on Medicaid and students, one on Medicaid's role in child, youth, and adult mental health, one on Medicaid and early intervention, as well as a recent mini brief with NACI and CLASP on the role that Medicaid plays in supporting the early education child workforce. In addition, as I mentioned, we have longer reports with lots of state-specific data on varying issues, including our recent report on Medicaid's role in small town and rural areas. Next slide. So finally, for more data and information, definitely check out our website. We have state-by-state general coverage data in addition to that school district coverage data. We have coverage data by congressional district. And we also have a really great state data hub on our website. It's at one of the tabs at the top where you can pick your state and see a bunch of coverage data along with lots of different policies that your state has elected or not elected to pick up in the Medicaid and CHIP space. And we even have a comparison tool where you can kind of look at choose like your, a state next door to see how your state compares to other states. So with that, I look forward to talking more about how all of this relates to kind of the current federal debate, and I'm happy to turn it back to Dr. Ross. Thank you so much.
Thank you, Ann. That was with surgical precision. Thank you and in a way that was accessible, getting our audience to fully understand the scope of the Medicaid program. I wish I had the power to teleport you and that presentation right into the Capitol today, so you could give that presentation to our elected officials and just further educate them about the importance of this program. One question before I invite Jessica in. You mentioned that there's a proposal for $780 million in cuts. What proportion of the Medicaid budget does that proposed cut represent, roughly?
So yeah, it's about $715 billion. I could go back and check. There were different targets out there. Yeah, sorry, we just got the language about a day ago. It will depend on the state in terms of impact. But just as a reminder for folks, Medicaid is a state federal financed program where the federal government picks up, I want to say it's like 67 cents on the dollar on average. So for every dollar a state spends, the federal government will pick up about 66, 67 cents, and the state picks up the difference. That means for every reduction in the federal dollar that the state's going to lose even more, right? They're going to lose proportionally more than that. And so the state can either raise taxes, cut benefits, cut eligibility, cut provider payments, or take from other parts of state budget programs. So like K through 12 education to make up those gaps. So they really have limited choices when that federal funding is reduced to kind of make up those budget gaps. And as we know, many states operate on balanced budgets within like a 1 or 2 year window. So, this could create really difficult decisions for states if these levels of cuts were to move forward. But we'll have more. Again, the language just came out like, I think at 10 o'clock on Sunday night. It's a great Mother's Day gift to me. And so we're still analyzing it, and more to come on kind of state specific impact as we kind of unpack the language and the different policies and what it means.
So the real impact as it gets closer to children and families and states is not just mathematical. It's actually not just additive, it's exponential.
That's right. And this is only over a 10-year window. And many of these policies don't go into effect for like the first few years. So if you look over the next 10-year window, these don't just shut off after 10 years. They keep going, and effects, again, would be exponential and increase even further beyond that initial 10-year window.
Thank you. Thank you so much. And let's invite Jessica into the conversation. Welcome, Jessica. Can we get, Jessica's on screen. Terrific. She's with Day One Strategies, former White House senior advisor. And so, Jessica, let me pose the first question to you. Anne did a terrific job of sharing some of the broader community impacts of Medicaid. Can you also share on the positive side, what are some of the recent advancements in school-based Medicaid services and how those services fit into the broader health ecosystem?
Sure, happy to. I was fortunate when I started my Medicaid career to work at the District of Columbia's Medicaid agency. And one of the things that I did there was I went around to all of the schools in the city to teach them how to bill Medicaid. And it was a very challenging assignment, and one in which stuck through with me throughout my career. If there was ever a time in my career where I could have the opportunity to fix this and make it simpler, I was going to try and do that. And luckily, for 4 years, I had a boss who was very committed to making sure that we were doing everything we could for kids and to strengthening access to healthcare, especially mental health care in school. And as I said, this was a passion project of mine. And so I really was able to leverage, my position at the White House in the Domestic Policy Council to really move forward in improving school-based health services and allowing schools to leverage Medicaid. So when I got to DPC, one of the first things that I did was I stood up a coordination meeting, kind of working group, if you will, between the Departments of Education and Health and Human Services to improve communication and the delivery of healthcare to kids in schools. And this coordination work group helped produce a series of letters from Secretaries Cardona and Becerra on available federal resources to expand access to healthcare in schools. And it sparked a new partnership between Ed and the folks in HHS who run school-based health centers. Thanks to this new partnership and funding that President Biden secured, there are more school-based health centers now than ever before, and the partnerships between schools and existing health centers is stronger than ever before. And, I'm really proud of this work that my colleagues and I advanced over the last 4 years, because it really laid the groundwork to implement the school-based health services provisions in the Bipartisan Safer Communities Act. These are provisions that were passed, no pun intended, on a bipartisan nature. Both Democrats and Republicans were committed to improving access for children in their healthcare in schools. And, thanks to the efforts of the coordination work group, the HHS team had already started thinking about how to update guidance to states and schools to make it easier for them to bill Medicaid, which allows schools to free up their time to deliver more health care to children. And BISCA, the Bipartisan Safer Communities Act, it's a little acronym that we call it BISCA, it required HHS to issue this documentation and an administrative claiming guidance. So it was really great that the coordination work group had already kind of started and got a leg up on this work. BISCA also provided $50 million in funding to states to study how best to leverage Medicaid and expand or strengthen their existing school-based health services programs. And finally, BISCA required the departments to create a technical assistance center for schools and states to share info and leverage resources. I'm hopeful that this partnership will continue in the current administration. I went on it yesterday, and luckily I still saw the Technical Assistance Center up. So if folks have questions on any coordination efforts between the departments of Ed and the Medicaid agency, that is a great resource to look into. So those are my top of mind advancements. We've had more states actually leverage Medicaid and expand the services that are available for Medicaid funding in schools. And so we've seen a really great movement towards expanding access in schools.
Thank you, Jessica. It's a reminder. I'm hard pressed to think of when I pay my federal tax bill as a taxpayer. I'm trying to imagine a federal tax dollar that is better leveraged and more powerfully leveraged than the Medicaid dollar. We heard from Ann how it leverages state dollars and support. You just described, yet another compelling example of how the Medicaid dollar leverages school-based funding. So this is a powerfully leveraged for whatever faults Medicaid may have in 2025, and I'm sure at the age of 60, we can do better by the Medicaid program. But I hope our civic leaders and political leaders recognize the powerfully positive leveraged impact of the Medicaid dollar. And what are some other maybe under-recognized, underappreciated ways that Medicaid policy shapes early intervention and even mental health services for kids?
Yeah, so I'll throw a link in the chat. As I mentioned, we actually have a great short fact sheets. I know this is a lot of information. So we've been trying to put out 1 to 2 page fact sheets, high level information, but with a lot of great links to data and resources. But Medicaid plays a really important role when it comes to early intervention in treatment for toddlers, especially when it comes to Part C. Nearly all states leverage Medicaid to support students in early intervention programs who are also Medicaid eligible, which, as I showed in the graphs, many of them are, to really support access to the services and to help financially support the states in their ability to deliver those early intervention services. So if you're interested, I would definitely take a look at the link in the chat, look up for brief. We have some really great data in there and resources about kind of more specific ways that Medicaid supports early intervention. I would also note that, as Jessica mentioned, we have the Bipartisan Safer Communities Act, which I'm going to get into like Medicaid walk talk, but Medicaid has this really important benefit called the EPSDT benefit. That means that if a kid needs a screening, treatment, service, diagnostic care, and it can be coverable by Medicaid and they're on Medicaid, that they should be able to access it, right? That there shouldn't be limits on that. They shouldn't be making it unduly difficult for them to access that they have access to that service. We know the reality on the ground in terms of talking about improvements is not always that case. This is just really, gold standard benefit. But the Bipartisan Safer Communities Act, again, on a bipartisan basis, instructed the Secretary of HHS to do more oversight of implementation of this benefit and just more technical assistance to states and resources to states to say, hey, how can we work with you or a state-federal partnership to make sure that this promise is becoming a reality on the ground for children and families. So again, they put out some guidance on this. We have a lot more on our website, But this is an opportunity, this state-federal partnership, and we're hoping that we'll see more come out of this administration in terms of follow-up on that provision in the Bipartisan Safer Communities Act. But again, to work with states to make sure kids get the things they need.
Thank you. Let me ask, throw back to Jessica, and I want to ask both you, Jessica and Ann, this question from each of your perspectives. How did the recent federal proposals or budget negotiations signal potential shifts in Medicaid funding priorities and its impact on children? So, and just a reminder for all, CGLR is a nonpartisan organization, as is this event, but we're looking for factual analysis about these proposals, and this is not an invitation for lobbying.
Thanks, Anne. Do you want to go ahead and start, since you kind of already talked about a few of them, but happy to layer on.
And I can talk a bit about process, just for folks that don't live in this space and aren't familiar with kind of the process around this. So what Congress is currently considering is a budget reconciliation bill. And a budget reconciliation bill is kind of a special, different type of bill that has different rules than like a bill that has regular order or normal kind of regular order. And essentially it means, in addition to being able to be passed by a simple majority in the House, in the Senate, where you usually have the filibuster, this has special privileges, this type of bill, and can pass in the Senate under this streamlined process where they can, again, essentially have a simple majority. Now, the bill has to meet some certain constraints around the budgetary process in order kind of to meet those, to have privilege, to get access to those special rules. But we have seen Congress pass these budget reconciliation bills both on a bipartisan and on a partisan basis in the past. This current effort, I think it would be fair to describe as a partisan effort, largely driven by the majority in the House and the Senate. That includes a number of proposals around tax, around SNAP and food benefits, around healthcare, other things that I know very little about, defense spending, things like that as well. But it is a very large bill. And what we're kind of talking about is one component of it that would specifically reduce federal support or federal spending on programs within the healthcare space, primarily Medicaid, also ACA related programs. So maybe Jess, I don't know if you want to talk a little bit more about any of the specific provisions, but I just want to provide that kind of backdrop for kind of where things are right now.
I think that's super helpful for context. And I think, Anne made a couple of points early on about ultimately what we could see with reduced Medicaid funding in states. Since we're talking about schools here, I think the biggest concern that I have is the downstream impact of having less money in state budgets to provide Medicaid will, create holes in their budget. And, we'll see reductions in education budgets, for example. If there is less money for Medicaid, to pay for healthcare in schools, that money is going to have to come from a state's education budget. A lot of the biggest proposal, I think, that has gotten a lot of airtime in the majority's proposals that were released earlier this week is Medicaid work reporting requirements. And while that isn't necessarily a policy that directly affects kids because it's applied to adults, it will impact children because it's parents of these children that might get caught up in red tape. They might not be able to apply or keep their coverage, which means that their children will lose coverage. There's some more kind of mundane proposals, which is to get rid of a Medicaid rule that the Biden administration finalized that, prevented children from being disenrolled for non-payment of premiums if their parents couldn't afford their premiums. The rule also ensured that children had access to coverage immediately and they didn't have to wait, in a kind of coverage lockout period. So there are specific challenges and policies that the Republicans in Congress are proposing that will definitely affect kids, both their, from their access to care and coverage and enrollment, to states' ability to pay for these services. So I don't know, Anne, if there are other ones that you wanted to highlight in particular, but those were the ones that came to top of mind for me.
No, I think that's a great summary. There's more in there. I think there's like 30 provisions or something, and there's a lot in that bill, and we're still unpacking it. But as Jess mentioned, I think there's some policies that will have a direct impact on children, no question, and then others that will have this indirect impact of states having less money in their budgets, and how do they make up for that, right? And you could even see things like increase in prior authorizations and like utilization management, right, where you kind of not necessarily eliminating benefits, but tightening up access to those benefits to kind of reduce spending in a way that could really potentially prevent children from getting the care they need.
Yeah, thanking you both. I mean, this all sounds pretty grim and sober. Is there anything positive in the coming reconciliation conversation that would constructively and positively benefit children and families, or is it mostly the kind of doom and gloom we've been hearing?
I will say that the CBO, a nonpartisan scoring arm of the legislative branch, said that this is going to take coverage away from 14 million people. I'm not sure there's anything positive from any policies that takes healthcare away from individuals.
Thank you, Jessica, and thank you for not beating around the bush. Let's do this. Let's invite Paula and Mo into the conversation, who, by nature of their leadership positions, are even closer to the ground about how Medicaid affects and impacts children and families. Paula and Mo, thank you for joining the conversation. Paula from NACI and Mo from Utah. So a third of Medicaid kids across the country are school-aged. Half of kids are served by Medicaid across this entire country. 40% of births, and in many states, more than 50% of births are Medicaid supported. And we just heard from Jessica and Ann what the budgetary impacts could be if things go forward in a way that is not constructive for the benefit of our children. So Paula, Ann and Jessica shared their thoughts about how these funding priorities might impact children. What risks do you see for the development of young children if Medicaid access is restricted or even unstable?
Yeah, absolutely. So, I think a lot of the things that Anne mentioned, we're concerned about as well, as far as, early intervention services under IDEA, Part C and Part B, so preschool, special education as well, and, children's access to those programs and what that means for the workforce as well. So, we're thinking about how that impacts the children and their development. And we know that when we intervene early, we have the ability to support children for better outcomes in their future. We're also concerned, and I'll talk about this a little bit more in a bit, but about the impacts of of these cuts on the workforce, the early childhood education workforce, and the fact that without these supports for children, educators are having a really hard time in the classroom already. So we're really concerned about that. And I know, Mo, you were going to start and share a little bit on that as well. So I'll kick it to you and kind of round out in a second here.
Sure.
Yeah. Hey, and Mo, can you speak to Voices for Utah Children also recently released an article entitled "Healthcare Isn't the Only Thing at Risk." So yeah, pick it up from where Paula left off, and what were your key messages in that piece from Voices for Utah's Children?
Well, when you look at Utah, and Utah's kind of a unique state, even though not different than some states, but we have the youngest population in the country per capita. So about 30% of our population is under 18. But we also have an interesting dynamic that about 30% of our population is senior citizens. So we're really concerned because we're going to see cuts at both ends of the spectrum in this case. 50% of our children access Medicaid, so about half of the enrollees in the state are children. And a lot of them are in our rural counties. Now, trying to tie it together with what Jessica and Ann were talking about as well, we just finished our legislative session in March where we saw our income tax cut. So we've been on a 5-year bender of cutting income tax. And so we have less money now in our overall pool. Once these cuts start going into effect, it's not like we can automatically reopen the budget process. So we're locked into this for 25, 26 at a minimum. And we have already been behind in a lot of these areas. So when Paolo was talking about childcare, Utah has one of the lowest rates of access to childcare, access and affordability. We don't utilize school-based Medicaid to the level we should be utilizing it already. We have one of the highest rates of mental health issues amongst teenagers in the country. So our concern is, number one, the direct effect on children, but the secondary effect is going to be, because of the way Utah is geographically situated, a lot of our rural counties are really deserts already, and we're really concerned about the effect on some of the rural hospitals. We already have challenges there. There are parts of Utah that do not have pediatricians. They only have family practices if they're lucky. Rural hospitals will be at risk in this situation. So we're really concerned about the direct effect on children and families, but also the economic impact that's going to come down the road.
Yeah, and unpack that a little bit if you can. Oh, I mean, those of us who've been in and around Medicaid for a long time, I recognize the role that Medicaid plays as an economic engine and in the workforce of a state and a community. Say a little bit more about that for Utah.
Well, you made a great statement earlier, which people should be quoting, is it's one of the best programs in terms of leverage that the federal government has. And so you have a situation in Utah where we have a population that is growing. We need to leverage these resources to the best of our ability. Medicaid and CHIP, in our case, is one of the best investments we can make in terms of a dollar spent in terms of healthcare and future outcomes. And yet, once we start seeing these rollbacks, like an example is, we're not waiting for the federal government to put in a work requirement. We have right now we're bringing forward work requirements in Utah. There's actually a town hall a legislative hearing tomorrow night. And one of the things that you also touched on is a lot of the people that the work requirement's going to affect are caregivers. So we already have a problem with people not being able to go to work because of childcare problems, because of caring for an elderly parent or for a sick child. Taking away their benefits is not going to help that situation, which is going to hinder the economic output of the state. And that's really something that doesn't get addressed enough.
Yeah, thank you, Mo. Paula, just extending from that observation, talk a little bit about how shift in Medicaid funding might impact the early education workforce.
Yeah, thank you for that. Absolutely. So, at NACI, I'll start by saying this, we ground all of our work in the early childhood educator voice. So I'll kind of be speaking from that perspective today and from the data that we collect from them on the issues that are impacting them. So that's sort of where I'm coming from in sort of my talking points here. So, one of the things that we know is that because of underinvestment in the childcare sector, about 13% of early educators don't have access to health insurance. And mostly it's because because their employers can't actually afford to provide it. And 28% depend on Medicaid for coverage. So of course, this means that their wages are actually low enough for that to be possible, for them to be qualified to have Medicaid. So that's an issue in itself for such a demanding, impactful role. And also for reference, the median wage for early educators is lower than about 97% of all other occupations in the US. So to kind of get into it a little bit here on what we're seeing. So we do these annual surveys that go out to about over 10,000 early educators in the field. And our latest one found that educators with access to benefits, including health insurance, were more likely to report wanting to stay in the field. And we know this is a field that is suffering from a lot of staffing shortages. And, as mentioned, there's childcare deserts and things like that. And they're stemming mostly from the shortages in the workforce. So folks are leaving the field. And so that gives us a little insight there on, the importance of benefits, which, we know. So kind of linking it back to this conversation here today, these large proposals for cuts to Medicaid would mean that more of the workforce, the ECE workforce, would be without coverage. So this not only impacts their health and safety, as we know, their health and well-being, as we know, but also it could make the staffing shortages worse. Because these folks might go out of the field somewhere else to gain benefits and have better wages, which is understandable, right? So this also will drive the supply shortage, and then we'll see families across the country continue to experience bad or worse shortages for supply, unable to find childcare. So, I think also linking back to what we said on earlier intervention and special ed services, this also could be something that drives educators out of the field if there's cuts to those programs that should be there to support them so that they can support the children in their care to address their developmental and behavioral needs in the classroom. And then, of course, kind of linking back to most conversation on the workforce. If we don't have educators to care for the children, to educate our children, about 70% of children under 6 have parents in the workforce. And so we know that's important for folks to remain employed and to not have issues there, in the workforce, continuing their work. So yeah, I think, the last thing I'll say on this is that we're also really concerned about the impact on these Medicaid cuts on state budgets, like Jessica mentioned, and specific to early education as well, because obviously we'll need to be filling those holes that are going to be left by the Medicaid cuts. And how do we do that? Some states are going to have to make cuts to education. So also uplifting that in our work.
Yeah, Paula, so what comes to mind as I'm hearing both you and Mo speak to this, I'm picturing a family. I'm picturing a 30-year-old mom who works either at a nursing home or is an early childhood educator. And she's got a 4-year-old. And I'm imagining in the worst case scenario, perhaps very realistic scenario, what we're talking about here in terms of these cuts that trickle down to New York or Utah. Kind of a triple whammy that mom may be looking at. One is her job may be at risk if the agency is more unstable. Either the entire job could go away, or her health benefits could be impacted. There's the impact on the child, because now some of those economic supports that that the child has in early education and early childhood experiences are at risk. And I'm imagining what the impact of this scenario on thousands and hundreds of thousands, if not millions of families across the country is in terms of the economic well-being and communities. So I mean, it's not hyperbole for me that this would have a devastating reach and impact on young families, whether it's Utah, New York, Missouri, Alabama, or Texas, or California. But Mo, do you want anything you want to on that rather grim scenario? Anything you want to elaborate on that in terms of how local communities in Utah are recognizing this potential impact, or maybe they're not recognizing it yet?
They're not recognizing it yet. I'm glad you brought that up. And I think the challenge is we use a term a lot. We haven't reached the pain point yet. This is the first step, I think, in that pain point, right? Where people are going to start seeing any one of the scenarios you just laid out, start whichever comes first. And then there's going to be that snowball effect because it's going to be they either lose benefits, um, a nursing home potentially closes down, a rural hospital closes a unit, et cetera. And then it starts really picking up steam. And the challenge is going to be coming back from that. Like we can see the immediate impact in front of us, but there's the economic impact that's going to be longer term. But also we don't talk enough about the long-term impact on the child, right? It's not just that we're going to lose this benefit today, it's going to be the effect on the child as we move forward. The last thing I wanted to come back to, and I apologize, but it was more on the economic piece. The other piece that doesn't get discussed at all in this discussion is we helped run a bill a couple of years ago to make sure that all children had access to health insurance. And the bill would have cost the state $4 million to make sure all children that didn't have insurance would have access to insurance. The state would have saved $9 million just on unreimbursed charitable care. And the hospital systems would have saved close to $50 million in unreimbursed charitable care. That's real dollars. And that doesn't get talked about. We all talk about the cost of Medicaid. The reality is, if this goes forward the way it's presented, states are going to get hit with a much bigger bill than just losing that Medicaid reimbursement from the federal government. They're going to pay for it in a different fashion, and that cost, we all know on this call, is much higher than if there was actually insurance in place.
Thank you, Mo. And that leads us to what I'd like to do now is shift to a full panel discussion, bringing Jessica and Ann back to join Mo and Paula. And this is if we can get past our anxiety and worry about what's before our federal leadership, legislative leadership on reconciliation. We had an op-ed, we saw an op-ed this past week, a very thoughtful op-ed by former Oregon Governor Kitzhaber. And in the op-ed, he shares that the basic structure of Medicaid was developed 60 years ago. That structure may no longer fit the needs today. So simply defending the status quo of Medicaid is not enough. And so point well taken, former Governor Kitzhaber. But I just want to ask our panelists, getting past the immediacy of the proposed cuts, from your perspective, what is one actionable, perhaps affordable recommendation you would have about the Medicaid program that would strengthen and not merely defend what we have today? And I'll start with you, Ann. What would you like to see Medicaid do better or more of or differently?
I have a few, but I'll start with one or two, because I think there's absolutely opportunities. Medicaid is a very large program. It's very efficient, but as I mentioned with EPSDT, making that promise a reality on the ground with additional oversight and support to states and implementing that is a big one. Enforcement of mental health parity. We know when we focus upstream on prevention, early intervention, treatment, that we're less likely to have emergency room boarding and very expensive stays in pediatric residential treatment facilities. And yet the OIG has found that there's lots of compliance issues with mental health parity in the private sector, also Medicaid and CHIP. Unfortunately, there's been some actions just as of yesterday on the commercial side, where there was a final rule under the Biden administration that is now not going to be enforced as far as I can tell. I'm sure Jessica can talk more about that. But again, I think focusing on what we can do through EPSDT, through mental health parity to go upstream to more efficient, more cost-effective prevention, early intervention strategies instead of, waiting till there's a crisis. We need services there too, because there's always going to be a role for that, but not just focusing on kind of the residential treatment side of things. Again, important role there, but also on home and community-based services. What happens when that child leaves that residential facility? Are they provided with supports when they are going back home? Are there outpatient programs so they can stay at home at night? Intensive outpatient. So again, I think some opportunity across systems, also in Medicaid, to kind of do more there. And then lastly, I'll just say, we have seen more and more states, as we've seen in Oregon. When I worked on Capitol Hill, I worked for Senator Wyden, who was a senator from Oregon. So I got to know their model quite well. And they really focus on kind of the health-related social needs. And we've seen more and more states focusing on health-related social needs, thinking about food security, housing security, how do we support kind of a family broadly, recognizing that all of that plays into their health. We've seen more and more states focus on health-related social needs. Again, sadly, the last few weeks, we did see this administration unfortunately pull back on some guidance from the past administration that was kind of guidance to states on, hey, here's some parameters and how you can move forward with pursuing these types of initiatives within Medicaid. To be determined what next steps look like on that, because we still have states that have their active waivers and are moving forward. It's unclear whether they'll approve future state waivers, and if so, what that'll look like. So perhaps we'll see more, again, unclear. But again, I think there's lots of areas where if we have the time and energy to do proactive thinking and not just having to be so reactive to like budget cuts all the time, that we are seeing in states, coverage, community health workers, doulas, they are really thinking kind of outside the box. So I could add on more, but just to get us started, and Bob, I'll hand it back to you.
A great basket of thoughts. And by the way, I'm not following the chat really closely, but I just took a peek at it. It's animated. It's pretty much on fire, guys. So a lot of good information and links in the chat, and some high energy, passionate, insightful comments as well. Jessica, your thoughts on what we could, in a better place, what we could do to improve Medicaid and not just cut it back?
Yeah, I think mine is less exciting and sexy than what Anne described. I mean, I appreciate the governor's op-ed program. Oregon is not Mississippi or Alabama, and they are in a state that actually is generally, supportive of Medicaid. And so my thing is more of returning and getting back to basics, making sure that the enrollment process is easy for folks, that we can cut back on paperwork, that it is not such a burden to apply for and renew your coverage. It seems pretty kind of as I said, basic, but we saw during the last couple of years with Medicaid unwinding that the more we can automate things, the better it is for people, for states. We were able to retain coverage, pretty well. And so I think it's just kind of getting back to those basics, not only just the eligibility enrollment processes, but, I think one of the things that frustrates me with how Medicaid is set up is that we have states, not to criticize Oregon, but are doing new and inventive things, but they're not paying providers well. It's great if you are trying new, models of care, but if you're not, again, getting to the basics of paying your providers a sufficient wage or payment to ensure access, that is a problem. And so I think for me, it's kind of returning back to the basics and getting the foundation, getting every state on a level playing field. So, every one of the 75 million people that's enrolled in Medicaid and CHIP has equal opportunity and a fair shot to having great health care.
Thank you, Jessica. Paula, what would you like to see
Sure.
happen to
Yeah.
improve Medicaid?
I think adding to some of what Jessica said here, we hear a lot from early educators. They are grateful that they are able to get healthcare through Medicaid, of course, for them and their children. However, there's so many administrative burdens for them. And so, how can we make it easier for people to access, to get care, and to not have delays in their care and get the care that they need? I think it's important not to just expand the coverage, but also to think about ways to make it easy to facilitate access to it. We think about also things like expanding coverage for the widest range of low-income families, in addition to the reducing administrative burdens, like I said, for those who apply for coverage, and then also boosting sort of the outreach to make sure that people know that they actually qualify for the program. I think is also important, and support them with the enrollment process as well.
Thank you, Paula. Mo?
Well, two things. I'm going to piggyback on what Ann said. We have to somehow get to a proactive system. When you look at it just from an economic model, we are spending so much money being reactive. And so that's where we could modernize the system, looking at reimbursing people for prenatal screenings in more meaningful way, for early childhood screenings, et cetera. So I think developing and expanding on the proactive piece of Medicaid and CHIP. The other thing is, a couple of people mentioned like outreach to the people who are accessing Medicaid. I think we need to educate the general public on what Medicaid is. I think so many people really don't understand. They get the snippets they hear. We've been talking because the work requirements coming up in Utah as a discussion, as I mentioned earlier. And most people, it sounds great if you're talking to someone like people should work if they're getting this benefit. But the reality is they are working. And the people that aren't working are the caregivers, the people with a disability. We know that, right? So I think there's a lot of constant education about Medicaid and the fact that it's a good investment, it's a good dollar spent, and it's producing good outcomes, so that we can get more support from the general public, not just the people that are utilizing the product.
Thank you, Mo. And your comments remind me that we've never done, when I say we, it's a pretty global we as child advocates who care about public policy. We haven't done a terrific job of the narrative of the Medicaid program. I think for too many decades, it's just been seen as the equivalent of welfare program for in health. It just has never, and I wonder now if we're paying the price for that relative lack of storytelling about the power of Medicaid. And so I wonder if we've done a disservice to our communities for those of us who lived in that space. The only thing I would add to the great observations that each of you offered for me, and this is putting my pediatric hat on, I'd love to see an advancement in how Medicaid programs position mental health, behavioral health, and school-based settings more robustly. When I look at how diseases and conditions that impact Americans over the last several decades have fared, and we tend to see improvements over time in cancer treatments, in heart disease, in hip and knee replacements, in treating arthritis and so many other conditions. But mental health has been either flat or worsening in terms of anxiety, depression, suicide rates among young people. I think it got exacerbated during the COVID years. So I don't think we've potential of the Medicaid program around children's mental health. And so that would be my 2 cents on that front. With that, thanking our panel as we move into our Q&A session. I'm going to turn it back to our colleague and great supporter, Michelle Hyman. Michelle, you've been teasing questions out from the from the chat, I believe, and you're going to offer them up to our panelists. And we've got, I think, I ended this session 2 minutes ahead of schedule, Michelle. I want some props for that. But I think we've got about 15 to 18 minutes for a Q&A with our panelists. Michelle?
So we have an audience that is fired up. They're like this, we want to know what we can do. So what are your thoughts on what can be done to influence the budget reconciliation process right now? What can we do as folks that are vested in this and want to do something? Maybe I'll start with Anne or Jessica.
Well, happy to start. CCF, we are a nonpartisan policy research center, so we do not directly lobby or anything like that, but we do educate. And so we've been putting out a lot of resources, and I've noticed in the chat and kind of other points about, and Mo and others have made this point about the need to just really educate about what Medicaid is, who it serves. I mean, in many states, it's not called Medicaid, right? It's called Badger Care or Peach Care. So just basic information about the role the program plays in different states, who it is serving, information. And there's a lot of great analyses that have come out over the last few weeks and more to come about information about how many individuals in Medicaid are working and how much of potential coverage loss would not be because you're not working, but because, as we saw with the unwinding of the public health emergency and a lot of coverage loss, even for children who we know were likely eligible, just jumping through it. Jessica mentioned that red tape of like being able to log on the portal with the password that gets mailed to you in the mail and it's 10 days late and you've missed your deadline, and then the portal should, all of those things that have nothing to do with whether or not you're working and whether or not you need health coverage. So, I think we, again, are just really focused on educating, and you all have such unique stories, unique voices. And so to the extent that you want to express the things that around education that you think would be helpful for folks to hear, I think that is worthwhile.
And I'll just add, since I'm no longer a government employee or bound by any nonpartisan nonprofit status, to put a finer point on it, I think if you can call your representatives, your congresspeople, your senators, particularly if your representatives are Republican, to hammer home to them the importance of Medicaid, how much it means to you, your community, to your school community, the benefits that it provides to children and helps your state and your schools, kind of, again, just show the importance. I can say my time at the White House, having personal stories was always the biggest and most impactful thing that we could do to lift up a policy change that we wanted to make. And I think the more people, particularly the electeds who are making these decisions during the reconciliation process, hear people's stories and, the direct impact that Medicaid cuts would have to them, to their communities, to their schools, is incredibly important.
That's right. No numbers without stories and no stories without numbers. Right, Jessica?
100%.
Anyone else want to add anything to that question before we move on?
I would just add one thing. I would urge people to contact their local legislatures in their states because, for example, in Utah, if we're going to bear the burden of these in terms of our budget and cuts to other programs, they should be made aware that people are going to hold them accountable, because that's the give and take in this. Yes, contact your federal legislators. I firmly agree with that. But you may have more of an input with the local legislator, getting them to put pressure on federal delegates.
All right. Well, thank you to our panelists, Jessica, Paola, Mo, and Anne. And I'm going to turn it back over to Bob for some final closing comments. And yeah, to wrap us up.
Okay. Are you sure, Michelle? Do you want me to do this?
I'm very sure.
Listen, just a big shout out to our panelists. You guys were just terrific. Thank you for your comments today and insights, but also what you do day in and day out on behalf of children and families across this country. This issue that we're talking about, Michelle, today, the issue of the Medicaid program. It's a strategic issue for sure about the future of our children and a thriving, inclusive democracy. It's a moral issue, as came up in the chat. But for me, as a person of faith, it's also a spiritual issue in our nation. And I'm going to close with a quote from Isaiah 58. And they that shall be of thee shall build the old waste places, thou shalt raise up the foundations of many generations, and thou shalt be called the repairer of the breach, the restorer of paths to dwell in. Each and every one of you in this campaign network of CGLR and our panelists for sure, each of you is trying to restore a path of thriving and well-beingness for children and families. You are trying to restore a path to dwell in, about a thriving future for our children. And so I just want to take a moment to thank each and every one of you for what you do on behalf of children and families in this country. You are repairers of the breach and restorers of paths to dwell in, and much love for each and every one of you for what you do. Thank you, Michelle, for your support, and thank you to the great team at CGLR for hosting this sobering but enlightening panel discussion.